right, so today's lecture is going to be over two of the more common GI complaints, diarrhea and constipation. Now we know diarrhea and constipation are pretty much opposites, right? But I like to cover them kind of all in one lecture because abnormal stools are a very common chief complaint, and there are a lot of different things that cause diarrhea, and maybe not as many that cause constipation, but still they're big topics to cover. So I wanted to cover them independently. And that's what this lecture is going to be about. So here are your instructional objectives to help guide you through this lecture. And here's our topic outline, what we're going to be covering today. Diarrhea, we're going to be covering acute versus chronic. We're going to look at a lot of the infectious etiologies for diarrhea. And so I would recommend that if you have not brushed up on your microbiology, that you definitely take a moment to go and brush up on that. I have posted in the supplemental videos some really good osmosis videos that help kind of remind you of the different types of bacteria and viruses and things that cause these illnesses. So I think it'd be a good idea for you to go check that out. Then I'll also kind of take a step back and talk about some of the non-infectious etiologies and kind of how to break it down and decide what the workup is and how to treat it. And last but not least, we are going to cover constipation. It is a little bit less complicated, I would say, than diarrhea, but we will spend some time covering that as well. I totally love the Awkward Yeti. They're some of my favorite, cartoons. The best. So we're going to be covering diarrhea. Let's go for it. So diarrhea can range from a lot of different things. It can be acute, self-limited, it can be severe, it can be life-threatening, it can be chronic. And so you have to be able to understand what is causing the diarrhea. You have to determine what the patient's normal bowel movements consist of, because every single person, if you ask them, if you kind of polled the audience, every single person is going to have a different normal as far as normal bowel movements are concerned. And so you can't really diagnose someone with diarrhea without knowing what their normal bowel pattern is and how it has changed with what they're presenting with, right? So most cases of diarrhea are acute, benign, and self-limited. And coming from the ER world, I can tell you this is completely accurate. You know, in the ER world, we see so many people coming in with acute diarrheal illnesses, and a vast majority don't require much of a workup and are treated pretty empirically symptomatically. Some cases that are chronic might be associated with underlying disease like IBD, lactose intolerance, celiac disease, and some of the other things that we'll talk about. Generally speaking, when we talk about diarrhea, we talk about acute versus chronic. We have acute diarrhea, which is usually anything 2 weeks or less. And the reason why we say this is acute is because most of the acute causes of diarrhea are infectious. And by 2 weeks of infection, this infection should have already kind of dissipated. So anything more than about 2 to 3 weeks is going to be considered more of a chronic. And the hard and fast definition of chronic diarrhea is greater than 4 weeks of duration. There's some really specific criteria for diarrhea. Has to do with the osmolality or the liquidity of the feces, like how wet it is. However, I think everyone knows what diarrhea is and has had it at some point in time. So I think you can pretty much rely on the patient's history to help determine whether or not they actually do have diarrhea. But technically speaking, it's more than 3 bowel movements per day, or liquidity of the feces, right? Like I mentioned before, there are so many different causes for diarrhea. And so in clinical practice, it's really different, first of all, to distinguish between acute and chronic diarrhea, because the causes are so different between the two. And then from there, you can kind of break it down and try to figure out what it is that's causing it. So first we're going to talk about acute diarrhea, not necessarily just infectious, but this is a nice little chart to help remind us of the acute infectious diarrheas. So you can see that after we divide it into acute and chronic, the next thing we divide into is non-inflammatory versus inflammatory. And so inflammatory diarrhea are going to be the ones that cause blood in the stool, inflammation, right? Blood, positive white blood cells in the stool, right? Inflammation. And so this blood plus diarrhea, I can't spell diarrhea. I missed an A. Blood plus diarrhea equals dysentery. And I'm sure you have heard that term before. So that's what dysentery. So these types here are going to be the more bloody inflammatory stools. These non-inflammatory are going to be the kind that don't have blood in the stool, more watery in consistency. And so that's another way to kind of help further subdivide the causes of acute infectious diarrhea. And we are going to go kind of through the more common or the more commonly asked about on testing etiologies and go through them more specifically. So, acute diarrhea. The most common causes of acute diarrhea are going to be infectious agents. Like we mentioned before, those are mainly going to be viruses. That is the most common, like a viral gastroenteritis. However, other things that can cause acute diarrhea are bacterial infections and medications, which is always a really important thing to ask your patients about because there are several types of medications that can provoke diarrhea. Like we mentioned, by far the most common, and what I see in the emergency room, the most common cause of acute diarrhea is going to be viral infections. Rotavirus, nowadays, we have a vaccine series that we give young children, so it is less common than it used to be. However, the Norwalk or norovirus family are the most common types of viruses. More severe forms would be due to bacterial infections, things like things we hear about on the news, Shigella, Salmonella, E. coli, Campylobacter, Clostridium, both perfringens and difficile. Although we don't really call it Clostridium difficile anymore, we call it Clostridioides difficile, but either way. C. diff. Other things, protozoa can cause acute diarrheas. Giardia can sometimes be acute versus chronic because it can take a while. Other things like entamoeba, so amoebic dysentery, and then crypto is more in HIV type patients, so immunocompromised. Medications. So antibiotics are by far the most common provoking agent for diarrhea, and we call this antibiotic-associated diarrhea. And the major culprit here is going to be this one, C. diff. C. diff. Other things that can cause diarrhea, well, obviously laxatives, other types of antacids, and the rest here, magnesium-containing agents and things. So definitely always ask your patients about what medications they're on, if there's any change to the medications. Other things that can cause acute diarrheal syndromes are syndromes of malabsorption, including like a lactose intolerance. Although lactose intolerance can also be more chronic, depending. Ischemic bowel can cause it, and then some intestinal tumors, which are pretty rare. So, because of the nature of diarrhea, it helps distinguish among infectious causes, like we mentioned before, the acute non-inflammatory diarrhea, which are usually watery and non-bloody. They're usually mild and self-limited, and they're most commonly caused by a virus or a non-invasive bacteria. Now, I will leave the whole invasive versus non-invasive to patho, but essentially, if it invades the lining of the gut, then you tend to get more inflammatory reactions and bloody diarrhea. This is not invasive, therefore it makes sense, and you don't tend to see the fecal leukocytes or lactoferrin, which come along with inflammatory diarrheal conditions. Usually, since they are so mild and self-limited, most of these evaluations are just are very minimal. We mostly treat symptomatically, and in most cases, it's just kind of supportive care. Although there are cases where it can be more severe. If it lasts beyond 7 days, then might need more warranting of evaluation. And we'll go through that a little more in depth. And then in contrast, this is a contrast to acute inflammatory diarrhea, which we mentioned before. This is usually going to have blood, pus, or fever. Pus can sometimes also be described as like mucousy. And these are caused by invasive or toxin producing bacteria. They do have present fecal leukocytes or lactoferrin. Lactoferrin. These do usually require more routine stool bacterial testing, like toxins or cultures. And like we said, dysentery is diarrhea with blood, distinguished from other conditions like acute exacerbations of ulcerative colitis, right? Or even Crohn's. And diarrhea that persists more than 14 days, usually not attributable to a bacterial pathogen, because even the bacterial pathogens are self-limited to some point. Although the exception to that is going to be C. diff. C. diff can be present and persistent throughout that, and it's called diff because it is difficult to treat, right? And those can be evaluated further. All right, so let's talk about important history, right? We can't diagnose diarrhea without getting a good history. So is the stool bloody or melanotic, right? We want to know. This will help us determine if there's inflammatory nature to it. Other symptoms: fever, abdominal pain, vomiting, because certain infectious illnesses tend to have more vomiting than others, and fever present or not present, okay? Anyone in the family or group with similar illness, right? These communicable diseases, such as like norovirus and things, can be transferred from one person to another pretty easily. And then also in group settings, like where there's family picnics or get-togethers, or they eat at the same restaurant, that will help determine causative factors. Recent travel, always ask about travel when it comes to diarrhea. And hiking, trips, camping, those kind of things, because of parasitic infections, people drinking out of stream water and things like that. Are your symptoms always linked to certain foods? Like every time you drink milk or eat dairy, is that when the diarrhea comes, right? Do you have any other medical problems, especially those that cause immunocompromising conditions like AIDS or even hyperthyroidism, which can kind of speed up the gut and cause diarrhea as well? And then any recent changes in medication. Medications we always have to ask about, especially antibiotics, okay? Ask about that specifically. So evaluation. Like we said before, over 90% of patients with acute non-inflammatory diarrhea, the illness is mild, self-limited, and responds within 5 days to just simple supportive measures such as rehydration and plus or minus antidiarrheal agents. And these are usually, like we said, usually infectious in origin, and they resolve without any intervention. Laboratory tests in this setting with a non-inflammatory, mild, self-limited type of diarrhea, usually unnecessary unless you're worried about severe fluid loss, dehydration, electrolyte imbalances, things like that. Really, you just got to interview the patient, ask them those same questions we just talked about, help picking an appropriate and cost-effective investigation. You're definitely not going to go hunting for something if the symptoms are mild and appear to be kind of viral in nature. What we do need to consider, a prompt medical evaluation in certain cases. So certain alarm things that come up where like, I better look into this a little more. So signs of inflammatory diarrhea, which we know already would be high fever, white blood cells, bloody diarrhea, and severe abdominal pain. If patients come in with that is not typical of a non-inflammatory diarrhea, right? That's indicative of a more inflammatory, and those do require a workup. If they have 6 or more unformed stools in 24 hours, so they're losing significant amount of fluid, should consider more of a workup. If they have profuse watery diarrhea or dehydration, work them up. Frail, older patients, nursing home residents, immunocompromised patients, any recent exposure to antibiotics, or hospital-acquired diarrhea, because these tend to have some different type of bugs that are present and C. diff present. And then anyone with systemic illness, someone that looks toxic, doesn't look well, should definitely look into it more. So in physical examination, you're not going to be able to hang your hat on a diagnosis just based on your physical exam. But what you're really looking for is kind of the level of hydration. So the level of hydration, we know we can look inside the mouth, looking at the buccal mucosa, looking for dryness in that area. In severe cases, you can check for capillary refill or turgor, those kind of things. Presence of abdominal tenderness, peritonitis, things like that. And then, of course, we know severe dehydration, organ failure. Marked abdominal pain is not usually seen with just a plain old diarrheal illness, so that indicates something else going on. And then, of course, altered mental status due to either infection or dehydration. This is from your textbook, current, and it's kind of a quick look at an evaluation of diarrhea. And so, if a diarrhea presents and is less than 7 days old, you're looking for these signs, kind of what we looked at in the last slide, the severe illness indicators. And so if they have those severe illness indicators, you're going to order all of this right here. Looking for things, probably need to be admitted to the hospital, potentially. And then you also have to consider empiric antibiotic therapy while you're waiting for a culture, especially if you have these things that are positive. Now, if they don't have any of these alarm kind of signs or symptoms, we can move down to the no. And in that case, most of the time, it's just symptomatic therapy plus or minus anti-diarrheal agents. This is Imodium over the counter. Now, I was always taught that if anyone had an inflammatory type diarrhea, bloody diarrhea, or really any kind of diarrhea, I try not to have patients take loperamide if I can avoid it, just because a lot of times things just have to kind of run their course. But it is an option, is over the counter. And then bismuth, Pepto can help as well. It's also over the counter. And of course, if it's still not getting better after a week or so, you have to consider doing more of a workup if you decided to go on the conservative route initially. All right, so let's go through some of the lab tests. If we need to do a workup, these are some of the things you want to look for. So CBC, pretty routine with anyone that coming in with abdominal pain or severe diarrhea, considering dehydration. You're looking for anemia, white blood cell elevation. The metabolic panel, you're looking for electrolytes, signs of dehydration. You're looking at the BUN and creatinine, looking at to make sure that kidney function is normal. And then the CMP also includes liver enzymes. It's good just to note because sometimes you can get hepatitis that can kind of fall into these foodborne or endemic country illnesses. Stool samples. Now, I'll tell you this, working in emergency medicine, there's no better medication or tool that you can use to get someone to stop having diarrhea than to ask them for a stool sample. I'll tell you, like, the majority of the time when I ask a patient to give me a stool sample of this profuse diarrhea they're presenting with, it's so hard to get a sample, and that helps me. I know it might be kind of a crude way of evaluating, but if a patient truly is having profuse diarrhea and they're there for an hour, you would think they'd have at least one bowel movement that they can, catch for you in a cup. But either way, stool samples are important if you need to make kind of a further diagnosis. We're going to look for several things, one of which is a fecal leukocytes or lactoferrin. These are white blood cells and byproducts of those that are usually seen in more inflammatory types of diarrhea. You should definitely also consider, stool cultures, but those do take time. There's also toxins that you do on the stool, including C. diff toxin and some other toxins that are present. So those are kind of some of the things that help you differentiate. Also for stool sample, you look for things like ovum parasites, OMP. And then if you're really suspecting Giardia, you can also get the antigen for Giardia. One of the newer tests that we have available that is really a good kind of bang for your buck and get pretty quick results is this multi-pathogen molecular panel, or we still call it stool PCR or stool study PCR, and it's pretty rapid, usually back within a few hours, and it basically rapid panels PCRs a bunch of different pathogens, including the more common bacterial, viral, and parasitic. So it is a really useful tool, and most facilities are resorting to this as their kind of primary diagnostic tool, because these stool cultures do take so long to come back, and this gives you kind of an answer pretty quickly. Of course, there is the tried and true bacterial stool culture. It does take a while to come back, and in most cases, if they're sick enough to be admitted and have the stool culture done, you're going to start them on empiric bacterial therapy anyway. It says here that most lab tests examine stool culture really for the three main illnesses, which are Shigella, Salmonella, and Campylobacter, which these are also covered in the PCR. So, one other thing, if you're suspecting recent antibiotic use, C. diff toxin is really important to get. And I guess what I should mention kind of before we go any further is when you order these, they're all kind of considered stool studies, but in most cases, you have to actually order each one of these, and usually it's kind of in a bulk order set, and just click it and go with it. If you're really suspecting C. diff, you're going to get those stool samples and cultures, but you then treat empirically until you know that's what it is. And then stool guaiacs, these can be done at the bedside. You do a quick rectal, or you can use the stool that's been collected to send, and you can look for blood in the stool, microscopic blood that you can't see with your eyes. Last but not least, this is definitely not in the ER world, but if patients are admitted and they have blood in the stool, and they have kind of this acute on chronic kind of diarrhea, you should do a colonoscopy to look for signs of IBD, although they're not always done during a specific flare because of risk of bowel perforation. And then CTs are also really useful. They help looking for other causes, especially in patients with like abdominal tenderness, looking for signs of colitis, IBD, diverticulitis, and other things that can cause acute abdominal pain and diarrhea. All right, so treatment. As we said multiple times already, acute diarrhea is usually self-limited and does not require hospitalization nor any specific treatment. Now, you'd want to consider hospitalizing patients that are severely dehydrated, especially elderly patients or pediatric patients, patients that are unable to tolerate or hold down PO fluid. So before any patient's discharge, you should always do what we call a PO challenge. And this is actually something that you can put in an order for. The nurse will give them something to drink and make sure that they can tolerate and keep it down before you send them home. And you should always document that they tolerated a PO challenge. Patients with significant bloody diarrhea should be admitted to the hospital. High fever, toxic appearance, those are no-brainers. If they are self-limited and do not require hospitalization, it's really not that important to identify the specific agent, right? It's really not that important because you're just going to treat them symptomatically anyway. Specific therapies that you can do, rehydration is one of the main things that we do for patients. And rehydration, generally speaking, on an outpatient basis, things like Pedialyte or Gatorade are superior, although anything that you can keep down water. In pediatric patients, I like to recommend popsicles, especially Pedialyte popsicles, and things that they will take and keep down. In patients that are more significantly dehydrated, more severe, they will require, IV hydration, and usually in the form of normal saline or lactated ringers. And pretty much across the board, in patients that are having multiple episodes of diarrhea and presenting to the emergency room, I usually give them fluids. especially if they're vomiting and having diarrhea. Kind of get them back on their feet, kind of get them bulked back up with fluids, give them some nausea medication, kind of, watch them check their electrolytes and their CBC. And by the time that comes back, you give them a PO challenge, they're good to go, and they go home for the most part. And that's for those that have kind of the more self-limited disease. Obviously, the mainstay of treatment is treating the underlying cause if you're able to identify it, especially if it's a medication-induced or a lactose-free diet for those that are lactose intolerant. You can also do a trial of NPO, so keeping the patients from eating or drinking anything to see if that helps stop it. As far as antibiotics, if they're on antibiotics and that's what you think is causing the problem, you need to discontinue those antibiotics immediately and check the patient for C. diff. However, in some cases, when patients seem okay, they're able to go home, you can do empiric antibiotics, but it's usually not warranted. Usually diarrhea is self-limited and not indicated. In cases when you don't have access to those rapid PCRs for stool studies, you can consider empiric treatment, especially if you're sending off stool cultures and waiting for them, and in patients with more severe illness, you would definitely consider starting empiric therapy. And some of the best empiric therapies are going to be fluoroquinolones like Cipro. That's usually kind of our go-to, Cipro. All right, and we kind of already mentioned these things. Other things that we mentioned, Imodium, which I tend not to prescribe, Pepto-Bismol, and then the diet is also important. So you don't want to go have a meat, steak dinner, and ice cream if they have, gastroenteritis. You definitely want to recommend we like to say brat diet, so bananas, rice, applesauce, and toast. I also include in here crackers, broths, things that are very mild on the stomach. Avoid dairy products, and usually we recommend kind of clear liquids, Pedialyte, and Gatorade. Alright, so now that we've kind of talked about acute diarrhea a bit, there is a really nice up-to-date algorithm, which I already love. I love algorithms. So essentially you're assessing how long they've had this diarrhea, how many episodes they're having per day, what is the characteristics, do they have fever, is it blood, mucus, abdominal pain. You also have to assess for their volume status, are they severely dehydrated, and exposures, what they've been eating or who they've come in contact with, antibiotics or comorbidities. Has the patient been hospitalized for 3 or more days? If no, does the patient have bloody diarrhea? If it's yes, is the disease severe or highly symptomatic? If it's yes, then you have to consider bacterial cultures, E. coli toxins, stool leukocyte or lactoferrin testing, additional things like parasite, Giardia antigen, C. diff toxins, and things like that, depending on what they've been exposed to. And then initial management is only going to include empiric antibiotic therapy, fluid repletion, and then potentially some of the other medications to help stop the number of episodes of diarrhea. Now, if we come back up here, it is bloody, but it's not highly symptomatic. If they're afebrile and the diarrhea occurred in the setting of an outbreak, then we can consider doing this, which is some of the same stuff. And then over here, if the diarrhea was not bloody, then you have to assess for severe illness or high risk. If it's not, then you can kind of continue on thinking about other things like inflammatory bowel disease, pregnancy, and then work your way down. I like this. It's kind of a way to kind of test your brain out to see kind of if you understand the flow of what you're looking for. Again, when to admit a patient with acute diarrhea. So severe dehydration for sure needs to be admitted, especially in the setting of vomiting or they can't keep down oral fluids, because you're seeing them in the clinic or the emergency room kind of in a snapshot of their health. But if you can predict that when you send them home, they're still not going to be able to keep down fluids, they're having multiple episodes of watery stools and vomiting, you can imagine that over time that's only going to make their condition worse. Bloody diarrhea, like we mentioned, severe abdominal pain, severe infection or sepsis. Older folks, immunocompromised, and signs of hemolytic uremic syndrome, which we're going to talk about in a bit. All right, so we kind of covered the basics of of acute diarrhea. Now we're going to go kind of at a glance for each one, but we're going to go through some of the more common infectious etiologies of acute diarrhea, and kind of go quickly over the highlights, kind of how long it takes for the infection to start, what they typically present with, how we test for it, and how we treat it, pretty much. So when we talk about acute infectious diarrhea, there are really 3 major kinds, maybe 4 if you consider protozoa. But today we're going to be talking about these: viral, bacterial, and parasitic. Now for viral, usually, they can cause fever or they can not cause fever. You get some nausea, watery diarrhea, and usually self-limited, lasting anywhere from 3 to 7 days. Bacteria, on the other hand, can be either non-inflammatory or inflammatory. And when it is inflammatory, you can get abdominal pain and fever, peritoneal signs even. Parasitic Giardia usually is associated with fatty stools, gas and bloating, and we're going to go one by one through these. This is kind of an overview. So let's get right into it. We're going to start with the causes of viral gastroenteritis, and our number 1 is going to be rotavirus. Now, this is a crude way to introduce you to rotavirus, but this is what you're looking for. So the incubation of rotavirus can be anywhere from 1 to 3 days. The transmission is fecal to oral, so changing a baby's diaper and then touching their mouth, or kids playing with the same toys with rotavirus on it at a daycare facility. Generally speaking, the presentation is kind of this 2 to 3 day prodrome. They get this fever and a little bit of vomiting, followed by this non-bloody diarrhea, and they can have copious amounts of diarrhea, upwards of 10 to 20 bowel movements per day. And it looks kind of like what you see up here, this greenish yellow looking, foul smelling diarrhea. And it's a virus, so it is usually mild and self-limited, tends to peak in the winter and spring, and it plus or minus fever. Sometimes kids can have some low-grade fever. We see this a lot in little kids. Although now that we have vaccines, we have reduced rates. I still saw it a whole bunch, especially outbreaks in daycare facilities. Fecally contaminated foods, touching by food handlers. You can make the diagnosis usually clinically. You don't always need, cultures or PCRs or immunoassays, but if you do, usually stool PCR is best. Treatment, supportive care. Kids can get pretty dehydrated from rotavirus, so it's good to kind of keep an eye on those kids and teach parents how to look for dehydration, how to try to push fluids on the kids, especially when they're having 10 to 20 bowel movements per day. If I had to say there were any specific buzzwords for this when you're reading vignettes, I would say usually pediatric, associated with daycare, and then this yellow-green foul-smelling diarrhea that's self-limited. Moving on, another viral gastroenteritis that we talk about is the norovirus family, or also known as Norwalk virus. And some people even call this kind of the stomach flu because it's so common. Incubation anywhere from a day or 2. And again, fecal oral, you're going to see this over and over again. A lot of people not washing their hands after they go to the bathroom. Clinical presentation, patients usually have nausea, vomiting, diarrhea, fever, myalgias, abdominal cramping. It's the typical viral gastroenteritis that you see, and tends to happen kind of in close quarters. So it is one of the leading causes of foodborne illness in the United States, mostly from food handlers that don't wash their hands, and they handle, leafy green vegetables, fruits, and things like that. And they call it kind of the stomach flu or gastric flu. The good thing is that it is usually kind of a shorter course, so 12 to 60 hours, kind of like the flu, stomach flu. Patients can also have kind of a low-grade temp. Associated foods, it's really anything that you touch when you don't wash your hands, and especially those foods that kind of tend to carry water, like lettuce. Shellfish can also. Clinical diagnosis, so you don't necessarily have to do anything with these patients. You can kind of just say it looks like norovirus and just treat them supportively, rehydrating them and such. But if you have to, you can do PCRs. Usually that's kind of the best test to do for this. The buzzwords for Norwalk or norovirus are going to be cruise ships, because it's close quarters, also military bases for the same reasons, nursing homes. And so close quarters, usually what they kind of mention. There was an outbreak kind of at the Olympics a few years ago because of the Olympic grounds, where they kind of sleep all together. So keep an eye on that. Here's the Minnesota Department of Health released this in 2019, kind of teaching you what to do in the case of norovirus. It's pretty short term, which is good. Usually they feel better within a day or two of the illness. Next up, we're going to talk about some of the bacterial gastroenteritis. There are other viral gastroenteritis out there, but none of which can kind of pinpoint with symptoms. But we're going to move on to bacterial. First off is salmonella. If you've never heard of salmonella, you're probably living under a rock, because I think everyone at some point has heard of salmonella before, whether on the news because of recalls of products or, just it's a common bacteria that you hear of. The incubation period is anywhere between 8 and 48 hours, and transmission is usually from food. And the foods we tend to think of are eggs, poultry, and pasteurized milk, cheeses, juices, and then raw fruits and vegetables that are not washed well. You can also get it from equal-oral contamination, like most of these illnesses. Very often, these patients have fever with chills, nausea, vomiting, cramping, abdominal pain, and diarrhea. And it's usually inflammatory, grossly bloody, and can last anywhere from 3 to 5 days. Like we said, it can also have fever. These, because it is inflammatory, you will tend to see the fecal leukocytes or lactoferrin positive, and so the main way to diagnose is going to be with routine stool culture if needed. If a patient is pretty low risk and has mild symptoms, you don't necessarily even have to treat with antibiotics for salmonella. But if they're high risk or they have systemic dissemination, we usually give fluoroquinolone, usually Cipro, to treat these. And some of the buzzwords we see on vignettes and things are, eggs, poultry. I've always heard of like people using cutting boards to cut their chicken, and they use it to do other things, or they don't clean the area well. I also heard it like pet turtles, because reptiles can have salmonella, and kids can kind of play with their turtles and then put their hands in their mouth and they can get salmonella that way. Unwashed vegetables, tomatoes, fruits, veggies, and things. Another bacterial gastroenteritis that you usually kind of hear associated with not necessarily the same thing at all, but Salmonella and Shigella, kind of think of them together. They both start with S, and they're both inflammatory type of bacterial gastroenteritis. So these usually start within a day or two. Fecal oral in this case is more common than food, whereas we said with Salmonella it's more foodborne. This is more fecal oral. You get this abrupt onset of diarrhea with blood. cramping, tenesmus, and lethargy. Patients usually look pretty sick. Plus or minus fever. Usually, like we said, it's usually contaminated with human feces. And you get this person-to-person spread. Patients don't wash their hands after they use the restroom, and then they shake hands with someone else, and then they touch their iPhone, and then they put it up to their mouth, and I don't know. You can extrapolate from there. Diagnosis similar. Routine stool cultures, fecal leukocytes, looking for blood in the stools can help make the diagnosis. And fluoroquinolones, again, are the most effective. Usually they're pretty mild, and they can even be self-limited. Don't necessarily have to treat for the milder cases. And again, kind of things we see: veggie, salad, dairy, by mishandled. And the reason why salad is, when you wash lettuce, it's really hard to get all of the water off of the lettuce. And so these fecal contaminated water particles can kind of sit on there, and then we eat them, and we ingest it. Moving on, Staph aureus can actually produce an enterotoxin if it's consumed, and it can cause a gastrointestinal illness. The thing about staph is it has a really short incubation period, meaning if you eat something that has staph food poisoning, you're going to get symptoms usually within the first 6 hours, which is quick, okay? And so it is one of the most abrupt onset causes. You get this intense nausea and vomiting, and it can be pretty bad, plus or minus a little bit of diarrhea, and they usually get better within 24 to 48 hours. They usually don't have fever, and I always tend to think of it as these dairy kind of based products, egg products, like potato salad, egg salad, ham and poultry and things like that. Any food with mayo in it, really. And a lot of times they like to portray picnics. That's why I have this basket here. They'll say, oh, there's a company picnic. They had barbecue and potato salad. And, 5 workers, ate. And then within 5 or 6 hours, they are all throwing up and having problems. Most of the time it's clinically diagnosed, self-limited. Although you can test the stool for the staph toxin, and supportive care. It goes away pretty quickly. Buzzwords, like I said: picnic, egg and potato salad, mayo-based products. Campylobacter. So Campylobacter is another bacteria that causes these things. Usually the incubation period is longer, so 2 to 5 days before you start showing symptoms. And this is, again, raw or undercooked poultry, pasteurized milk, and water that's contaminated. And then puppies and kittens can also carry Campylobacter. Little kids play with their new puppy, and they put their hands in their mouth, and they get contaminated. The patients usually have kind of this fever, diarrhea, can be bloody, it is inflammatory. And it's usually self-limited, but not as quick as some of the other things. It can take anywhere from 2 to 10 days to get rid of. And these patients do usually have fever. Because it is inflammatory, you do see fecal leukocytes, and stool culture is the way to diagnose it. Treatment is going to be with fluoroquinolones again, or azithromycin. And the one thing they like to put in vignettes that is specific to Campylobacter is this co-presentation, or this presentation after the infection with Guillain-Barré. As we remember, Guillain-Barré is an ascending paralysis, so feet to head. And if you see it in a vignette, someone that had this fever and diarrheal illness and then starts developing ascending paralysis, you'll want to think Campylobacter. Another bacterial illness that we see is Clostridium perfringens. And in Clostridium perfringens, usually the incubation is a little bit longer than Staph aureus, but usually within 8 to 16 hours you're seeing symptoms. So it's still pretty abrupt onset. It's in food, and generally speaking, the associated foods I've seen is like rewarmed meat. So meat that's warm for a long time and then like gets kind of cool or pre-cooked, and then it gets kept warm for a long time before serving. That that can cause this to happen. And really what happens is you have these kind of spores, and when they are kept warm for a long time or cool off, they can when you reheat it, it can release those enterotoxins from the spores. Stools, usually they have this abrupt onset, profuse diarrhea, abdominal cramps, nausea, vomiting, and usually they recover without any treatment in a day or two. And you can test for the enterotoxin or a culture. Supportive care, antibiotics are not usually needed. Enterotoxic E. coli. So there are 4 different major patho-named groups of E. coli. ETEC is one of them. And ETEC is one that we tend to think of as a traveler's type diarrhea. It is not inflammatory. It is enterotoxic, but not hemorrhagic. So usually patients get this when they travel with contaminated food or water. It's contaminated with feces. These other countries that don't have good filtration systems. And I mean, most people know when they go to these more third world type countries, even Mexico included, they know not to drink the tap water. Okay, but there's other things that you don't think of, that patients don't necessarily think of, that can contaminate them. For instance, brushing your teeth with the sink water, or eating lettuce or salads that are washed with the sink water, right? Because lettuce tends to kind of hold that, tomatoes and lettuce kind of tend to hold that water. Another ice, using ice, right, to cool drinks, that also happens. So just keeping an eye on those different things usually causes this watery diarrhea, abdominal cramping, and it can last anywhere from 3 to 7 days. Usually they don't have fever. You can get stool cultures for it. And travelers, a lot of times it's recommended that you kind of take some Pepto, kind of if you start having symptoms, because it can help kind of nip the disease in the bud. But if patients are having consistent symptoms and they're traveling, then fluoroquinolones tend to help shorten the disease. Other things, so usually traveling goes along with ETAC. Okay. Now, another one of those strains, or STEC, which is Shiga toxin producing E. coli, is one of the other types, as well as this enterohemorrhagic E. coli. And these type of E. coli are inflammatory. And so this E. coli, excuse me, this E. coli 0157H7 is the one that we've heard, or if you're familiar with, that causes burger joint outbreaks. So I don't know if any of y'all are familiar with it, but I remember when I was younger, back in the early 90s, I think it was 93, there were 500 cases of E. coli infections from meat, from ground beef, and it was namely the Jack in the Box franchise. And I mean, there were 500 plus cases, and 4 kids even died because of this. And so I just remember being young and my mom just never taking us to Jack in the Box, just out of caution, but that's what I remember about this type of E. coli. It's abrupt onset of diarrhea. It's often bloody, abdominal pain with fever. Most of the time in adults, self-limited. However, in children, it is associated with hemolytic uremic syndrome. And we mentioned this earlier. This E. coli 017H7 is associated with hemolytic uremic syndrome. And hemolytic uremic syndrome, I'm not going to go into too much of the patho, but really you see 3 things with hemolytic uremic syndrome. And it makes sense with the name, right? So hemolytic is hemolytic anemia. Uremic, because of the damage that happens within the kidney, it doesn't filter properly, and so you get buildup of toxins in the blood, and you have increased BUN, or uremia, right? BUN, uremia. And then last thing you tend to see with this is thrombocytopenia. So those three things are the three major things you see with hemolytic uremic syndromes. And one of the main things that you don't want to do if you have hemolytic uremic syndrome or you suspect it, do not give antibiotics. It will make it worse. And do not give the patient platelets. It will make it worse. I'm not going to go into too much on that, but those are some things I just remember about it. Like I said, undercooked beef, especially like hamburger meat. Other things, unpasteurized milk, raw fruits and vegetables. This is inflammatory, so you will see positive fecal leukocytes, stool toxin, and the Shiga-like toxin culture. And then buzzwords are going to be, they might not exactly say hemolytic uremic syndrome, but they might give you this patient that is jaundice because of the hemolytic anemia that also has kidney failure and thrombocytopenia, right? One of the other ones that I tend to see thrown out in some of the vignettes that I've looked at is Vibrio cholera. And as it says in the name, it is a form of cholera. And it's not common in the United States. This type of Vibrio is more common kind of more third world countries where there's not good filtration systems for water. Usually the incubation period is 24 to 72 hours. And whereas this is not an inflammatory diarrhea, these patients can get sick very quickly because of the abrupt onset of explosive liquid diarrhea. And they tend to describe the diarrhea in Vibrio cholera. They tend to describe it as this rice water stool. And I don't know if any of you ever cooked rice, but the water that comes off of it is kind of whitish, milky looking. And it has these kind of little flakes that look like rice. And that's actually some of the lining of the gut that gets kind of sloughed off. They tend to see this obviously in endemic areas, but contaminated water and then shellfish and things, so vendors and food, and then also patients handling this diarrhea in third world countries where they don't have proper sewer systems, they can inoculate themselves that way as well. The one that they love to test about when they talk about Vibrio cholera is this need to promptly rehydrate. These patients tend to get dehydrated very quickly because they're having copious liquid diarrhea, and it can be explosive in nature. And you want to consider oral or IV rehydration with electrolytes. If we have to treat with antibiotics, if it's indicated, doxy is a drug of choice, as well as some of the second lines are Cipro, azithromycin, and ceftriaxone. So I guess you can see after a bunch of these different illnesses that Cipro is kind of a good choice for empiric therapy for some of these. And again, some of the buzzwords are going to be rice, water stools, and shellfish. We're going to keep going. So C. diff, I have it here as Clostridium difficile. It's actually now Clostroides difficile. This is an older term, but this is what I learned back in the day. Usually it occurs anywhere from 7 to 10 days after antibiotics. So this is why you want to ask patients about recent antibiotic dose. It can occur after even just a single dose of antibiotics. So you have to ask. It is imperative that you ask. These patients get abrupt onset diarrhea, usually bloody, with fever. And remember when we talked about toxic megacolon in the ulcerative colitis lecture, we said that C. diff was another major cause of toxic megacolon. So you can imagine this can get pretty bad in some cases. So it's very important to diagnose it. And the fever can be really high and the diarrhea can be profusely bloody. Like we said, association with antimicrobial drugs, and the ones that are typical culprits are going to be clindamycin and some of the beta-lactam antibiotics. And we treat this with oral vancomycin or fidaxomicin. And I'll let Dr. Paz kind of guide you as to when to use what. But it's really important that you look for oral vanc, not IV, because it needs to go where the infection is, which is in the colon. You can test the stool for the C. diff toxin. That's how you can make the diagnosis. And history of antibiotic use, especially Clinda or a beta-lactam. Now, patients that have antibiotic-associated diarrhea usually have C. diff. And patients with C. diff can get this characteristic manifestation in the colon called pseudomembranous enterocolitis or C. diff colitis. And I'll show you a picture in a second of what that looks like. But it can be pretty striking on colonoscopy if you have to make the diagnosis that way. Here's one of my favorites, Medcomic C. diff infection. Talks about kind of what it looks like, what to expect, and it even mentions the pseudomembranous colitis. Again, one of the other things I didn't mention on the previous slide was it's the most common infectious cause of nosocomial diarrhea. And for that reason, we take a lot of precautions when we have patients that we suspect to have C. diff in the hospital. So one thing I wanted to mention is C. diff, as it says in the name, difficile to treat sometimes. It can be a real booger to try to get rid of. And so in most cases, patients do well, you give them the treatment and they improve. Some cases can be very difficult to eradicate. And so as kind of a alternative means of treating recurrent and difficult infections is this fecal transplant. Okay, and it is what it says it is. Essentially, you get healthy donor flora, the healthy donor stool that has a normal gut flora, and you transplant it either by enema or by NG tube, or even capsules. They make capsules of poop, and you put it in there to try to kind of fix the biome within the gut. And it's really interesting. This is also a photo I wanted to include of a colonoscopy of someone with pseudomembranous colitis, and you see all these little yellow patches of pus all throughout the colon, and that is due to C. diff. Moving on to a few parasitic infections. This is Entamoeba histolytica. This is what patients tend to describe as amoebic dysentery. I know I've heard that before. It comes from fecal, oral, or contaminated food or water. It is not that common here. It is definitely more common in other countries. And patients can have an infection with Entamoeba and actually not become sick. Patients, if they do, have mild symptoms, including loose feces, low stomach pain, stomach cramping. However, you can get a more severe form of it associated with abdominal pain and bloody stools and fever. And rarely, but can happen, you can get invasion of the liver, and they can get these abscesses within the liver, and it can spread to other parts of the body like the lung and the brain, but that's very, very uncommon. Diagnosis for this is made usually by PCR, but you can also do other antigen testing and such. And the treatment for those that require it will be usually a metronidazole treatment. Another parasitic infection that we tend to see, and I've seen it in real life, and I have seen it on a lot on tests. This is Giardia lamblia, and Giardia is also a parasitic infection. You can see it here. It's a little live buggy. It swims around. The duration of the illness is usually 5 to 7 days, but sometimes can be longer. So this one can kind of bridge between an acute and a chronic diarrheal illness depending on when the patient presents. You get it from either fecal oral route or from contaminated water. And what I usually see in vignettes is drinking contaminated spring water. So patients that are camping and they drink water without filtering it. One other way that It's kind of not the nicest way to put it, but those that partake in oral anal sex can actually also get giardia that way. I'll let you think about that for a second. Clinical presentation is going to be this watery, foul-smelling, sometimes greasy, or steatorrhea or diarrhea. They also get a lot of bloating and flatulence associated with it. And I know when people say foul-smelling, it's like, well, what stool smells good? But this is, excessively foul-smelling. And the diagnosis is made usually by stool antigen. It's better, but you can also do a stool ovum parasites. And treatment, usually metronidazole or tinidazole. If it's not treated, it can become more chronic in nature. Again, buzzwords are going to be drinking not so fresh mountain stream water or patients that go camping. And like we said, causes foul-smelling, bulky stool, and it can wax and wane. So I had this elderly lady that came into the emergency room because she had this diarrhea, and she said, I've had stomach bugs before. They kind of, run their course, but it's been going on for weeks. She's had diarrhea for, 3 weeks or so. She said it's just not normal. It smells so awful. I said, okay, I don't usually order stool studies out of the ER, but this had been going on for so long. She was in her 60s, and I just, I started going down, asking her questions, and recent antibiotic use, no, any recent travel? And she's like, well, about a month ago, we traveled up to some national park, and we went camping for a while. I was like, oh, really? And she said, yeah, I went swimming in the water, and I didn't really think too much of it. I didn't drink anything that was contaminated or anything like that. I was like, And so we ordered stool studies, and of course those don't come back right away. We actually discharged the patient home, and I ended up placing her, I think, on Flagyl, kind of empirically, and ended up being giardia. It came back positive. And it made sense because she had been camping, and just from swimming in contaminated water. I mean, I don't know how many of y'all have ever gone swimming in these lakes and stuff, but innately you kind of drink it a little bit. I mean, don't chug it, but when you're swimming and things, sometimes water gets in your mouth, and that's how she got giardia. And I'll never forget her. I can even remember which room she was in. That's how vivid my memory is of this case. And I'm sure that'll happen to you as you get out and practice. There are other infectious diarrheal agents. Trust me, I did not cover every single one, but I just don't have the time to do that. You should know that there are special infectious diseases that happen in elderly and immunocompromised patients, especially HIV and transplant patients, because they're more vulnerable. And so other things such as Mycobacterium avium or MAC, Cryptosporidium, Cyclospora, or CMV. And I'm not going to go into too much detail on these. They're rare, and they're seen in a very specific population. If you're a chart person, in the current textbook, they have a pretty good bacterial chart, which is where I got most of my information for these slides. However, I also found these charts. They kind of put all of them together. I tried to kind of piece them together and have them here so that you could reference them if you're more of a chart person. And it has kind of all the important information that you would need to know to make the diagnosis. Also have continued these other ones here, and then viral and parasitic. So it's all here for you to kind of review. I know the quality is not great, but I think the content is there. All right, so we've graduated from acute diarrhea. Now we're going to talk a little bit about chronic diarrhea. So chronic diarrhea by definition is going to be diarrhea consisting of 4 or more weeks duration. And there are several different subcategories of chronic diarrhea that we're going to go over. There's inflammatory, which is usually like an IBD, so Crohn's or ulcerative colitis. There's osmotics, secretory, altered motility, lactose intolerance, and even fictitious. And then we're going to go through these kind of briefly. here's a nice chart from your textbook talking about what clues to look for each type. And then it goes through kind of the major players that are consistent with osmotic or secretory, inflammatory, different medications that cause chronic diarrhea, malabsorption, motility, chronic infections, and factitious. And then fecal impaction is also a potential cause. It's not really true diarrhea, but because you have a lot of stool, the only thing that can pass is the liquidy type. So anyways, we're going to try to go through these, not every single one, but try to briefly touch on them. But I liked this chart a lot. So first we're going to talk about inflammatory. So underlying cause of chronic inflammatory disease is not always understood. It's thought to be autoimmune. Usually the two major players in inflammatory chronic diarrhea are going to be Crohn's disease and ulcerative colitis. With Crohn's disease, tends to be less bloody and pretty profuse, with a lot of other extraintestinal manifestations. Ulcerative colitis, flares of diarrhea that is usually bloody, and we covered these in a different lecture, but should be considered when we think about chronic diarrhea. Osmotic diarrhea, so you can actually take stool and calculate the osmolarity of the stool, and because there are in the colon kind of this presence of unabsorbable or poorly absorbable things, it acts as kind of this osmotic pressure effect, and so you get shifting of liquid into the intestinal lumen, resulting in excessive water output, so by osmosis. And these diarrheas usually caused by whatever it is that's in the gut, and they tend to stop when you take away that item. So for instance, lactose intolerance is an osmotic diarrhea, and so you take away the offending agent and the diarrhea goes away. Other symptoms, other types of malabsorption, celiac disease, pancreatic insufficiency, and things like that can cause an osmotic type diarrhea. Again, poorly absorbed sugars similar to lactose intolerance. Laxative use can cause osmotic diarrhea, and then magnesium containing antacids. Secretory diarrhea, on the other hand, is usually characterized by just large watery diarrhea. No pain, and it's not usually related to food intake. It's there. And these are less common types of chronic diarrhea, but one celiac can cause secretory. It can also cause osmotic diarrhea. These other kind of really rare things like the vipoma, the carcinoid, hyperthyroidism, stimulant laxatives, these are a little more rare. There are diseases of altered motility or enhanced motility that can cause diarrhea. It's thought that if things are kind of rushed through the GI system, that there's not adequate time to absorb the water that's needed. So hyperthyroidism, when things are kind of turned up and throughout the body, you can get rapid transit of digestion, and that causes less absorption, and so you have increased water. Carcinoid syndrome can also cause this type. IBS is a major player in this. And then other states where you've post-gastrectomy or post-vagotomy. There are diseases of slow motility like scleroderma, but these result in bacterial overgrowth, and that causes problems with diarrhea. And it is actually kind of hard to diagnose this dysmotility-induced type diarrhea, and so it's usually more of a diagnosis of exclusion. Lactose intolerance, we've talked about that in a different lecture, but it is a major cause of chronic diarrhea. So one of the things that you should do on an initial evaluation for chronic diarrhea is to have the patient log their foods, log what they're taking, and even try a lactose test, where you take out dairy in their food and see if their diarrhea subsides, right? That's something else to consider. And last but not least, we talk about factitious diarrhea. Factitious means it is created, right? It's created by someone. So we tend to see it as self-induced. So either they put water or urine or stool in, or they self-medicate with laxatives. And we tend to see this in women with psychiatric disorders. So chronic diarrhea, again, history and physical exam, we have to look at several things, including, is it continuous or intermittent? Is it related to foods or liquids that we consume? And does it occur at night or during fasting, right? These will help us differentiate between secretory, osmotic, things like that. What does the stool look like? Is it greasy or malodorous, which would consider like a malabsorption syndrome or steatorrhea? Does it have blood or pus? Is it significantly watery? You want to consider whether or not there is abdominal pain. So we usually see that in IBS or IBD. Medications, diet, stressors, all this should be reviewed. And on physical exam, you're looking for signs of malnutrition, dehydration, or extra-intestinal manifestations of IBD, like episcleritis or dermatologic findings, right? There's so many different things that can cause chronic diarrhea, so you should really guide your assessment to what you're thinking at the beginning and not just shotgun everything under the sun. Go with what you think it is, go with the more common things, and then from there you can kind of branch out more if you need to. One thing to remember is that if you have these signs or symptoms of nocturnal diarrhea, weight loss, anemia, blood in the stool, you need more evaluation. And so this is also from your current textbook. It's talking about chronic diarrhea, excluding all of these things, and then moving on to look for certain things, including colonoscopy and biopsy and CTs and things like that. And so this kind of helps you look at that. Routine lab tests. So if the patient has had diarrhea for greater than 4 weeks, they should have some routine laboratory testing, initial lab testing done. CBC, CMP, including liver, calcium, phosphorus, albumin, also thyroid, so TSH, vitamin levels, PTE, INR, ESR, and CRP. And you should also look for celiac, like a TTG IgA. Even if you don't have signs of malabsorption, when I worked in the GI clinic, we kind of had this order set for chronic diarrhea, which included all of these things. Also included iron studies, B12, folate, albumin. Albumin is found in the CMP, so we would look at that. Hyponatremia is also in the CMP that we would look at. ESRs and CRPs help with inflammatory bowel disease, but you're putting these pieces together with the history and physical exam that you've gotten. Stool studies are also really important in chronic diarrhea. You're going to send them for O&P, electrolytes, and that's if you need to calculate the osmotic gap to determine whether it's an osmotic type of diarrhea. You're looking for blood, leukocytes, fecal calprotectin, remember, for inflammatory bowel disease, or lactoferrin, which is a sign of inflammation. Parasitic stuff, so O&P, looking for these things. Usually we get the PCR, has a pretty good panel of pathogens, and it comes back really quickly, so we tend to start with that. Osmotic diarrheas, we look for signs of that. We look for fecal fat and fecal leukocytes and things like that. Other things we do, usually initially, especially after patients present to the to the GI clinic after they've been evaluated by their primary doctor and things are not getting better or they can't find the etiology, they usually get referred to the GI specialist. And from there, they usually undergo colonoscopy, and that's to get biopsies and exclude inflammatory bowel disease and other things that can cause these problems. A lot of these patients also get an upper endoscopy, especially when you're suspecting like a celiac disease, for the biopsy of the small bowel. And then it's not necessarily initial testing, but some of the more advanced testing would include things to look for some of the more rare causes. And that's usually after you don't find anything after this. But you look for things like VIP or VIPomas, thyroid carcinoma, Zollinger-Ellison carcinoid. And so those are a little more, when you're reaching for something, when you really cannot figure it out. How do we treat chronic diarrhea? Well, the mainstay of treatment should be tailored to the cause for the diarrhea, because we've just talked about lots and lots of different causes. So really you have to determine what the cause is, and then from there decide on treatment. So we have, for IBD, we already went through treatment of that. For IBS, we talked about the treatment. For celiac, we talked about gluten-free, right? Lactose intolerance, we talked about removing lactose, dairy. And then kind of as a more generalized approach, there is loperamide, which is Imodium. There are some bile salt binders and other things that can help with chronic diarrhea. And then just, to round out our chronic diarrhea portion, there is an algorithm that is from Up to Date that kind of takes you through kind of the process of of determining what chronic diarrhea, what the cause is. And so this is kind of the algorithm of what we've just discussed. Okay, so we have talked about diarrhea for literally 75 minutes. It's hard to think that you'd have that much to say about diarrhea, but as kind of a wrap-up pearl, volume status is very important. Look for dehydration. A lot of times the dehydration is worse than the bug that the patient has. Look for blood. Look for inflammatory versus non-inflammatory diarrhea. In most cases, there's not a huge workup that's necessary, especially in acute diarrhea. If you do suspect that you have blood in the stool, high fevers, you should look for different causes. And then also keep in mind those electrolyte problems can lead to things that are more significant, like metabolic acidosis and hypokalemia. All right, so this would be a great time to get up, stretch your legs, take a quick break, and then we will talk about constipation. There are only 10 slides with constipation, so hopefully we can get through this last part pretty quickly. Let's go take a break. All right, so next up we're going to talk about constipation. So literally the opposite of diarrhea. And, I think patients, you see a bunch of different patients with these symptoms, but I would say that the majority of the patients with constipation wish they had diarrhea, and the majority of patients with diarrhea wish they had constipation. And I don't think one is necessarily worse than the other. They're both not fun things to have. As far as constipation, the first step in evaluating, similar to diarrhea, is you have to determine what normal is for each patient. As sometimes patients, normal bowel movements for them is maybe going 3 times a week. Some patients, they don't go every day. That's abnormal. If they don't go a couple times a day, that's abnormal. So really talk to your patient, see what their normal is, and see what has changed from the normal. Because constipation can be defined as infrequent stools, so fewer than 3 a week, not having many stools, or it can also be this difficulty, excessive straining, or particularly hard stools that make patients feel like they are constipated. Also, some patients just feel like even though they are going, that they just cannot completely evacuate the stool, and they have this sensation that they always have to go to the bathroom. There are kind of 2 major subcategories of constipation. One is primary constipation, and this is constipation that usually pain-free and cannot be attributed to any type of structural or systemic disease. And that's primary constipation. Secondary constipation is associated with systemic disorders, medications, or some sort of obstructing lesion. So here are some of the causes of constipation. Most common, I'll say by far, is patients not consuming the adequate amount of fiber or fluid intake, or those that kind of hold their stool or have poor bowel habits. This is by far the most common cause of constipation. It's recommended, right, that we have like 8 glasses of water a day. I mean, I try to have my water jug handy and keep refilling it, but there are days when I don't drink a lot of water. And then fiber, especially nowadays with our diets, our fast food diets and things, they do not have a lot of fiber content. And so we're lacking, and there's a lot of patients that suffer from constipation because of their diet. Other systemic diseases can cause constipation, like hypothyroidism is a big one. Diabetes can cause some constipation. Metabolic problems, neurologic problems, right? Especially like problems with nerve function in that area. Medications are a big player for constipation, just like they were a big player for diarrhea. But in this case, it's different types of medications. So opioids and diuretics, calcium channel blockers, NSAIDs, and other things like iron is a big one. Iron. Structural abnormalities. So having problems with rectal prolapse, things like that. These are more surgical or structural abnormalities. Slow transit, eating disorders, pelvic floor problems, and then IBS-C. So patients should all undergo history and physical exam, trying to figure out whether this is in fact primary, or if there's some sort of secondary cause of constipation to attribute it to. The physical exam should definitely include a digital rectal exam, and it's looking for abnormal anatomic variants, anal strictures, rectocele, prolapse, pelvic floor motion. So you can have the patient try to push out the examiner's finger and kind of feel the simulated defecation or the pelvic floor motion. Other diagnostic tests should really be considered in any of the following. So older than 50 years old, severe constipation or new onset, right? New onset constipation, alarm symptoms, so severe blood in the stool, weight loss, or a positive fecal occult blood or FIT. And then history, right? Colon cancer, inflammatory bowel disease. And we'll talk more about blood in the stool in our rectal bleeding lecture. CBC tests should include CBC, electrolytes, calcium, glucose, and TSH. And then usually these patients that have constipation, if it's bad enough and it's not getting better, they get evaluation, a colonoscopy. There are other more specialized examinations that can be done. I would not expect for y'all to know this. This is a very more specialized management. Usually this is for refractory constipation. So they're just not getting better with medical things. And so they can do manometry, which is kind of a pressure, but instead of up in the esophagus, it's done in the anal rectal area. There's also colon transit times that are done, and a defecography, where they look for pelvic floor dysfunction and things like that. So this is way more specialized assessment. Some complications of chronic constipation is FARE, and so I say it's not fair, I can't poop. That's fecal impaction, anal fissures, rectal prolapse, and hemorrhoids, right, from the constant straining that patients have. So should consider constipation in these. Here is our trusty algorithm for chronic constipation, and kind of looking and going from one thing to the next. I don't necessarily need you to know all of these different things, but it is nice to kind of look and see what's done. And then I also put here some of the major players, major drugs associated with constipation. The main ones that I tend to see are iron supplements, opiates, and diuretics. And see those. Treatment. So first off, because the most common cause of constipation is low fiber intake and low fluid intake, the major changers is going to be, of course, advocating for better health, better diet, increasing physical activity. Exercise is great for constipation. It gets things moving. High fiber foods. I love to give patients handouts on what kind of foods are best. Not all patients know a lot about this. Increasing fluid intake, having patients kind of keep track of how much fluid they're drinking in a day. And then usually the first step in treating is going to be starting them on some sort of soluble fiber supplements like psyllium-based fibers. However, I will say, depending on where you're working, that a lot of these patients with constipation, there are a lot to choose from for constipation over the counter. So I will say that many patients have tried things over the counter before they get to you. So one thing that you should definitely look at with these patients is what have they tried and how hard did they try with it? Did they take, one dose of Miralax and kind of chalk it up that it didn't work, or did they take the full cap full? You want to ask them questions about that before just crossing it out as not working. We tend to start with bulk laxatives and psyllium-based, fiber-based laxatives before we resort to more osmotic. But like I said, it just depends where the patient is in trying things over the counter and such. For us in GI clinic, by the time they got to us, in most cases, they were already on these things. And so we would start them on kind of the next step, the Amatizas and Linzesses and things like that. Some patients get so desperate that they have to use enemas. So over-the-counter fleet enema or things like that to try to get some relief. But if patients are having to do a lot of these enemas, we need to get them on something better controlling. A lot of times these are done in like bedridden patients and things like that, and the nurses have to kind of help them. Obviously, if we think there's an obstruction, we should consider surgery. And then here's a nice little chart of the different pharmacologic managements of constipation. I'm sure that you're going to be covering a lot of this with Dr. Paz, but just to kind of have it all in one place. Again, we like to start with fiber-based laxatives. My GI physician that I used to work with, he was a little old school. he liked to use flaxseed powder. He'd actually recommend doing 2 heaping tablespoons of flaxseed powder in water, have it like mix it up, dissolve it, and drink it with meals. And that's what he would recommend. And is a more natural. It's not psyllium based. It's not synthetic or whatever. So patients tend to have less bloating with it. But I mean, usually, like I said, by the time patients come in, they've already tried this. This is also over the counter, so they've probably tried this as well. The thing that I like to start with, if they've already been on some things, is Miralax. Has a pretty low side effect profile, less bloating, and so I usually try to start with that if they haven't already tried it. And then from there, kind of work my way up to one of these secretologues, which are usually Amitiza or Linzess. Linzess was the one that we used most often in our GI clinic. There's other stimulant laxatives, although these can cause cramps and kind of, because they're causing spasms and kind of stimulating things to move, so they can have problems with that. And then enemas, of course, those are just for acute relief. And then also we use these similar medications to clean the bowel or to prep the bowel for colonoscopy. And that includes mag citrate, which is over the counter. When should we refer patients? Well, constipation is a pretty common complaint, and there are a lot of things that general practitioners can prescribe and try over the counter. However, especially in those patients that we're concerned about, they should have a GI evaluation. When they have refractory constipation, those that have defecatory disorders, they can't get the stool out, anyone with alarm symptoms or greater than 50 should be referred. Nowadays, the colonoscopy is actually at 45, so you could consider sending them for that, and they can be evaluated. And so that is pretty much what I wanted to cover for constipation. We are at the end of our lecture. It has been a long lecture today. There were a lot of things to cover, and hopefully we covered them at a pace that helped you retain it. There are some really good videos on osmosis about the different pathogens, especially for infectious diarrhea. They go a lot into some of the microbiology and pathophysiology, which I think will tie in the two courses really well for you. Also take a look at some of the patho lectures and the 5 easy steps to approaching diarrhea. And that should help you kind of connect the dots and fill in the blanks. So if you have any questions, reach out to me, and I will see you next time.